when I went to UK, it was like working in a unit, and then you can move on to another one, and then once you gain experience, pass the exam, and you become a consultant. But then this new system came called the Kalman system, which was like American residency scheme. So you had 5 years of 6 years of training, and you pass the exit exam for neurosurgery at year 4, and then you get a certificate of training, and then you become a consultant. But a lot of things changed in neurosurgery. So neurosurgical practice changed. As we all know, there were a lot of technical advances which came in. The role of neurosurgeons started to shrink because of a lot of tumors being treated by pediatric radiosurgery and vascular things being taken over by the interventionists. But at the same time, there was a need for having multidisciplinary team-based practice so that decisions were taken by a group rather than by an individual. And the document called Safe Neurosurgery 2000, which was basically to look at the future demand and supply in the United Kingdom to match the training numbers with the consultant course, realized that the population was growing, so that was putting additional strain on the service. There were also emergency-led services were increasing by about 3% per annum, and because of the Royal College guidelines and head injuries, they were coming more and more to neurosurgeons, and that was increasing the workload. So the general load about common conditions was increasing, but whereas the specific conditions coming to neurosurgeons were reducing in numbers. So they came up with this modernizing medical careers in 2003, which was basically to provide training which was based on effective team working, multidisciplinary approach, and flexible training. So they essentially wanted to have more consultants who could do everything and have less people doing special things. So the training was made like that. So you had, after passing your MBBS, there was a 2-year foundation program, which is the present training scheme. And during these 2 years, if you want to be a neurosurgeon, you have to spend about 4 months in each year to do neurosurgery. But basic aim at that level is to make you competent enough to manage acute patients. Then after that, there is a national selection, which happens once a year, centrally, and that there we select trainees for the whole country at the same time through an Aussie-style selection. So we've got 6 stations which test a lot of different things. And after that, the trainees are given the unit which they have opted for, provided their marks are of that level, or they will get the second choice and third choice depending upon what they scored. And once they are offered, they enter the training scheme for the whole 8 years. So you start as the first year trainee, and then you progress to year 8, and then finally you pass out. But you have to pass the exam, exit exam, before you finish your training. Otherwise, you don't get the certificate of training. So essentially, we've got early years of training, which is from first year to the 3rd year. Why does it keep going off? And then intermediate years of training, which is 4 and 5 years, which so the basic training is for learning basic neurosciences, anatomy, neurophysiology, pathology, and management of acutely ill patients, and neurology as well. And this the second 2 years, ST4 and ST5, which is surgical training year 4 and 5, they learn common neurosurgical conditions and basic surgical approaches. And final years, they are managing complex neurosurgical conditions and learning more advanced neurosurgical approaches like far lateral approach and the MBD and stuff like that. So the curriculum is actually designed to address the requirements at different levels, which is very good, because the trainees are only expected to know that much, not any more than that. But the best thing that we have is there is a web-based assessment system called the IACP, developed by the Royal College, where you can have assessment of trainees on a regular basis, and that is kept on the system like this. So each placement, they have a global objective set, what they are supposed to do, clinically, surgical skills-wise, in the CV, publications, audits, etc. And they are assessed regularly by the trainer that they are allocated to. And all these things, problem-based assessment, clinical assessment, portfolio, and logbook, etc., they're all tested throughout. It's not like after 6 years they have an exam and you pass and you become a consultant. So it's done throughout, and at every end of every year there is a regional assessment. They are tested for what they have done, and if there's any problem, they may have to repeat the posting, or they may have special support provided. And after passing the exam, they get the CCT. So the advantages of having a system like that is very structured training, very supervised. There's excellent support for trainers, and we make sure that there's no bullying, harassment. They have a right to complain, and if they require support, they are given support and they are regularly assessed. But the disadvantages are that because it is a limited years of training, the experience of the trainees coming out through this system is much less compared to the trainees who are in the old system, where you could work as long as you feel that you're confident enough to go and become a consultant. And I feel, this is my understanding, that we are treating them with kid gloves. So neurosurgery, in my opinion, is a very stressful specialty, and person should have a different personality to be a neurosurgeon. They should be able to take stress and have long hours of working, but we're working within time limit. These trainees are protected like this. You can't work for more than 48 hours, and you can't take stress and this and that. And suddenly, when they pass out, they are unleashed on society and have to address everything that we are facing as neurosurgeons. And further impact came when there was introduction of 48 hours European Working Time Directive, which came in 2009. So according to this, no one can work for more than 48 hours in a week. So we reduced our training time from 72 hours to 48 hours a week, and did not increase the number of years of training. So you can't really train surgeons with so much reduced hours. And therefore there are concerns in UK, Europe, Canada, and USA about, I think US also has, they have reduced their number from 80 hours to 72 hours, but even them, they are feeling that there is an impact on training. So this is one thing which led people to think that maybe simulation is necessary. In the UK, there's increased emphasis on patient safety, so there are bodies like the Care Quality Commission, NHS litigation authorities, which are controlling the trusts where the hospitals are, and they are putting more and more pressure on the trusts to make sure patients are safe, which means, and patient expectancy is rising, which means that, and the fourth one is the government-driven targets. So anybody who's referred to a neurosurgeon has to be treated within 18 weeks, and there's not much capacity, so there are waiting lists, and that puts pressure on the consultants, and they try to do more cases themselves rather than giving it to the trainee, because it takes more time for the trainees to do the operation. So all these things are reducing the number of hours for trainees to be trained as surgeons, and like in the GMC now is driving this drive that all trainees have to have some sort of simulation on anything that they are going to do on the patients, without much funding being allocated. In India, correct me if I'm wrong, there is plenty of opportunity, so the volume of work is massive, but I do not know whether the training is structured. Is there any regular assessment in place? So when I was here, I don't think there was. I don't know about now. Professor Chatterjee would probably tell. Are the training standards the same across the country? I don't think so. And here also there's more media coverage and more patient safety focus. So all these things make it essential to have simulation, and that is what was the basis of having the boot camps. So you have to have facilities like we have the clinical science building, which is basically used for all kind of non-cadaveric simulation and boot camp related activities like history taking examination, positioning scenarios, consent, etc. This is our clinical skills lab, which is almost like a ward, so you can have patient examination and history taking, etc. Then we have a very well equipped cadaver lab, which has the operating theatre lights on each table. We've got eight stations with mobile cadaver tables, which can be moved from one to another. They can be folded into smaller ones if you're doing only a head. And there's a central projection. We've got irrigation and suction at every table. And then when we are running a course, we get operating microscopes, high-speed drills, micro instruments, and everything. So how did the concept came? So basically, it was decided nationally that we should have camps at every stage. So starting from the first year, it is not possible to have it every year, but first year when they enter, so we have the basic equipment that is used in neurosurgery, so they get used to that, so that they're not suddenly taken away aback when they start their program. And basically, the aim is to get them all together in one place for about 7 days and teach them the skills that they require for what they're going to do. So it just doesn't make them a better surgeon, but at least gives them exposure to what they're expected to do. And it also develops a good team of comradeship. So they all, know each other very well by the end of the week. So it becomes a very good thing in the future. It's like similar to pilot. So I used to run a beginners in neurosurgery course, which was basically for trainees who wanted to do neurosurgery, and those in the FY1, FY2 level, or any other people who wanted to do neurosurgery. So I exposed them to all the equipment that we were using and also history taking, examination, etc. And that was taken up by the SSC and it became the SC1 boot camp, essentially. So we taught them history taking, examination, interpretation of radiological investigations, and we had simulation on using the operating microscope, using high-speed drills, with the theory and troubleshooting, use of neuroendoscope, navigation system, halo applications, and fixing the heads with plates and things. So after it was presented, it was accepted as boot camp. So we added 2 more things to that list, and I was using the artificial head for simulating how to do a craniotomy. And this is a very good head created by one of the neurosurgeons who was trained with Professor Sepgupta in Newcastle, is Richard Ashford. He's working with Delta Surgical, and they have produced this, which is almost like a cadaver head. And also we trained them how to use EVD and ICP board on a model. So this is history taking, and we use trainees as actors as patients. So history taking examination was also part of that. So they learn how to do examination, which is very essential at that stage. And then operating microscope. So this is the model that Royal College uses. So I stole it from them, and we created a model which is like it's like a glass which is full of jelly, and there's a cherry inside. So it's like a brain tumor in the brain. They put a glove on top, and they under microscope they will open the dura and take the cherry out from the jelly, and then learn to stitch the dura under microscope. So that gave them the opportunity to have the eye-hand coordination skills developed. And we also had a session on high-speed drills, which was used on animal bone, and with the final one on drilling the eggshell without breaking the membrane. So this is also part of the SP3 boot camp. We also taught them how to suture, and these are very cheap things. The pig trotters, so they learned how to do suturing on these, and then they had theory on navigation system, which is very much part of neurosurgery now anywhere. And in the ST1 boot camp, we gave them an opportunity to do it on the on the Rowena head model. So they get a chance to use this system. So when they come into neurosurgery, they at least know these equipments. Similarly, for neuroendoscope, we had a simulation model for doing transnasal approach. And also endoscopic third ventriculostomy on a model as well. So they gave them an idea of what it might be like. It's not perfect, but it gives them some idea of what endoscopic third ventriculostomy would be like. So, and then we taught them ICP monitoring, which is very essential for ST1 because they're the ones who are going to put the monitors in. So they had the theory about ICP monitors, how to zero it, and then they had a model where they put in the bolt and do the zeroing on the model itself. They also learned how to fix the heads with the bioplates. They had simulation on halo application, so the actors were the trainees themselves, and they were really good volunteers. So how to apply halo without, of course, putting the pins in the head. It was just holding it. So that was the halo, and then we created an environment of how to make them understand and take on the stress within theater environment. So this is a scenario where the trainee has to come and put in an EVD. This is a very rude nurse who's treating the junior as they do treat very junior people, and then the NSLS. So they get the stress of. So she doesn't know which catheter to use, and the nurse is asking, and the NSL is pushing pressure that the patient is very serious. You have to rush in. So this is the environment. I do not know. I remember we faced as juniors that anesthesia would say, "Well, finish off quickly." So that kind of thing. So they get that idea as well. So this is the Rowena head, which was created by Richard Ashpoles and Delta Surgical, and the face is his daughter's face, and the name is based on that as well. So this is like learning to do a craniotomy on an artificial head. So it has got all the layers, the scalp, the bone, the dura. So it's quite a reasonably good model, and you can have this without the brain. You can have the model with the brain without the ventricles. You can have a brain with ventricles. So whichever way you want, and the cost, of course, goes up the more you need. And then they were exposed to instruments in neurosurgery. So that was for ST1, and I think it covered a lot for Rose. So they were prepared mentally to be starting as neurosurgical training. Then we decided that we should have one camp at the third year level. So that is when they changed on to become registrars. The ST1 to ST3 is like an SHO, but they must be learning what they're going to do. So we made sure that in addition to the theory that they have to learn, they also learn all the basic approaches in neurosurgery that they will be exposed to. So this is the poster for my second boot camp. We ran the second one in December this year, last year, and then the one before that was in year 2016. And before so these are the approaches that we were teaching. So for cranial approaches, the bifrontal theory, which is the trauma flap, parasagittal, occipital, posterior fossa, and the spine, ACDF, lumbar decompression, and microdiscectomy. And we thought that that was enough for ST3 level people. But for each approach, they had anatomy lectures, they had scenarios for consenting. And I think consent is a big thing in the UK, and I think it should become a big thing in India as well because the way things are going. Then they had positioning for each approach, on models or using mannequins, and then finally they went and practiced that on the cadaver. So they had a consent, they positioned the patient on mannequins, and then they went and did the approach. And we made sure that we make the environment as close to reality as possible. So they had use of navigation on the cadavers, use of sonopet or CUSA, and image intensifier for all the spinal approaches. But before we started the course, we sent them a list of questions to assess what their knowledge was before the course. And that was done through this is a European web-based learning tool called eBrain, which one of my colleagues from Leeds is also involved in that. So he sends the questions, and the question they have to reply to questions, and that comes back and stays on the system. And once the course is finished, they have to do the assessment again to know whether they have actually learned anything from the course or not. So this is Professor Destrio from France, who was very kind, comes and teaches anatomy and all, and it's got beautiful anatomy slides on all the approaches that we do. And that takes about a day for covering the anatomy lectures. Then this is people getting ready to go into the high-speed drill scenario. So there is a lecture on the high-speed drills, the kind of drills, the craniotomes, the theory, the troubleshooting, and everything. So they get the theory, then they practice this first on the animal bone, and later on, as I showed you earlier, on the egg shell. So we've seen that. So that gives them another trick to learn about high-speed drills. This is a picture taken by all of them holding their eggs. They also get a chance to learn how to use a CUSA. So we use fruits or liver, animal muscle to make them learn what CUSA is like and how it can be used. So, as I said, for every approach, the consent is very important. So we have a consent. I do not know Professor Chatterjee now, but I think it's becoming a nightmare. Consent is a big thing in the UK, and GMC is now putting more and more pressure on other things as well. So we have to reflect consent in the boot camps, which is very, very important. So lecture on consent, and we have to cover vulnerable groups like children, pregnant women, patients with mental capacity issues, how do you consent them. And this is something new which is called duty of candor, where if you make a mistake, you have to go to the patient and tell him what mistake you have made. You have to document in the notes. You have to send a letter of apology to the patient, and it remains on the record. And there is an investigation which happens, which tells what went wrong. So we have to cover that, medical legal aspects, and of course we use the scenarios. So this is a scenario which we created for a child requiring brain surgery for I think a craniopharyngioma, and the mother was not very keen. She's divorced, and her husband, who lives separately, wanted to have the operation, and she was refusing. So the thing was, who has the right to consent for a child? So we gave them like tricky situations so that they could at least think, and also tested their knowledge about consent. After each scenario, so we had groups of 3 people. So one was a patient, one was a trainee, and one was an observer. And there was a trainer who would give the feedback, like this one. Then we had positioning scenarios. I think I'll have to skip if I have to rush. So they learn how to position the patient on the mannequins. For this, for lateral position. And this is by the trainer telling them what to expect when you're putting the patient for example, for the renal anatomy. and then they come and practice it on the cadavers. So we use a navigation system, and similarly for the spine also the same scenario. They learn how to position the spine for example, trauma. So putting in the clamps first, and then turning the mannequin prone, and same thing for lumbar spine. So this was I'll be just 2 more minutes.
There are 3 more lectures.
So this is turning the patient for lumbar spine surgery in the knee chest position. And then they had this cadaver simulation for ACDF. So we had used image intensifiers for all patients. They did the pre-check X-ray, and then did the procedure, and then finally they did the check again. So we did the same thing for lumbar spine, and they were given the assessments and then finally the certificates. But this was how it was possible. So we had to have a lot of industry support. There's no money to run these courses, and this is free for the trainees. So we had to have financial support from the industry and material support, and that is how it was possible. So we have to think in terms of expenses, which are quite a lot for all these things. But still, I think this is something which has come to stay now in UK, and it is going to be possibly funded by the SPNS at some stage. Thank you very much.
Any questions or comments on what we've heard from Mr. Saxena?
Sir, regarding the duty of thing, that is what mistake you are doing, what sort of mistake you are going to just reveal to the patient?
Everything. This is now in UK. So if you made a mistake, for example, if a patient had a complication during the procedure which harmed him, or if you did something which is not correct, you have to come and tell the patient exactly what happened, apologize, write down in the notes, and then you have to put in something electronically, which is called the CAE. So there's a dating system where you can put the whole scenario, what actually happened. It will go to the risk management committee. There's a significant incident group which will investigate the matter, and then outcome will be found, why it happened, so that it doesn't happen again. And then finally, either the consultant in charge or the trust in charge will send a letter of apology to the patient saying, this is what happened, we're really sorry, and we're trying to do things differently. So this is very scary, but it is very, very good, because you are at least honest to the patients, and you can't really hide things.
Thank you very much. You guys walk a photo. You want to say something? Yeah.
A little bit of daily information. What happens is this, that from Monday to Saturday, we do have daily combined round of neurologists, neurosurgeons, psychiatrists, psychologists, radiologists, endovascular this. So as it so happened, they thought it was a little bit of mistake that we did not. They felt that they wanted to continue. So there will be one case presentation which has got a surgical interest also, and I think that we'll have to take this time, which will take no more than altogether 10 minutes. So please bear with that, but this is of neurological interest. Okay? It will have to start now so that they can, if they want to go away to their work, psychologists, psychiatrists, neurologists, so we can start that point, and then we'll continue with the other. Okay. So, yeah.
morning, everybody. I am Dr. Jackie Ganguly, Associate Consultant of Institute of Neurology. We are presenting two cases, two small cases. First case, 54-year-old gentleman presented with history of subacute onset ptosis. The main presentation was that ptosis and diplopia and left-sided ptosis. He had past history of head injury, fall, for which craniectomy was done. It was in 2015. But after that, patient was symptom-free. When he presented to us, we initially thought of that subacute ptosis with some query diurnal variation. We are not sure about that with diplopia, asymmetric onset. Maybe it's a case of neurovascular junction disorder, maybe myasthenia gravis. So we planned for immunostimulant test, RNST. RNST was planned on the very next day, but patient suddenly became very much delirious. So what was the cause of that delirium? We were astonished. The patient was so irritable. We thought of something else we are dealing with or not. There was no definite history of fever. The count was a bit raised. Maybe we thought we were dealing with some kind of viral encephalitis kind of thing. With associated some meningeal involvement. For that, we can explain some third nerve palsy. So we went for CSF. CSF was nothing suggestive. Cell count just a bit raised around 10 to 20. Protein a bit raised around 52. So when in benefit of doubt, we started both acyclovir and ceftriaxone. And we proceed for MRI. Actually, MRI was just done. And what was the MRI picture is very interesting.
Can you clarify one? Yes. Is the pupil dilatation now with pupil dilatation or not pupil
Pupil sparing.
pupil sparing? And was there any injury or anything?
No. And head injury was around 2015. And yes. So we want to see the MRI. Okay, in the MRI, in the midbrain, initially we thought there was obvious evidence of past history of craniectomy, but in the MRI midbrain there is some signal intensity. And when we proceed further, in details evaluation, it also saw that there was some abnormal midline hyperintensity in the midbrain, around the region of medial longitudinal fasciculus in the left side. So then we thought maybe we are dealing some kind of midbrain pathology, maybe stroke initially what we thought, or Wernicke's also is a good differential diagnosis with the presentation because alcoholic history, occasional alcoholic what we say. So NMO, Wernicke's, or even simple stroke. So these were the differential diagnoses. As there was delirium, so Wernicke's may be in high on the list. Yeah, midbrain intensity can be seen in Wernicke's, NMO, and obviously, yeah, eye signs would have been there. Eye signs, there are different presentations of Wernicke's, what we can say, not only restricted 6, it can involve also other cranial nerves, an asymmetric onset. So maybe say 3rd and 6th MLS involvement. So those can be possible.
Summarize the case. We have a case of long MRI, but this is a case of head injury long back. Improved. Craniectomy was done, cranioplasty was done, and present with ptosis and diplopia with mild some diurnal variation. So the teaching point is that when you see ptosis, diplopia, mild diurnal variation, which was not very clear, we thought of myasthenia gravis, and that was thought at that time. RNST, that is repetitive non-spinal was done, which is we do for myasthenia gravis, and this is the limitation of investigation also, and the borderline positive, and borderline nothing was in medicine. So he got a level of myasthenia gravis in Delhi and he came here. In 2 days' time, delirium started without any reason. Because myasthenia, you give pyruvate treatment, it doesn't cause any delirium. No steroid was given. So delirium was, we cannot explain why myasthenia gravis. We repeated RNST here, that is repeated now solution was negative. We did neostigmine test. Whenever we have diplopia, whenever we think of myasthenia, neostigmine is much better than any other test. Neostigmine is giving injection and seeing the improvement. And there was no improvement at all. So that was ruled out. Myasthenia was ruled out. Neuromuscular was ruled out. Now thinking of ptosis, diplopia along with delirium, now we have to think of something else apart from neuromuscular disorder. And CSF was borderline abnormal. At that time, MRI was not done. So again, I'm just talking investigation. When we see CSF abnormal, borderline, we think of viral encephalitis, and we started receiving acyclovir. And again, there was no clear evidence for that. When we got the viral test, it was negative. And then MRI was done again under anesthesia, and we found that small hyperintensity was there. So that I won't say that clear-cut vertical encephalopathy, but small infarct can be there. Why we not think of infarct as the first thing? Because small infarct should not cause delirium. Small infarct can cause eye sign, but not delirium. That's why it can be vernicus, it can be infarct. And apart from that, demyelination at this age without any reason is highly unlikely. Protein was not very high. So these are two are differential still, and patient is improving with time. So that was the case.
Second case is more neurological than neurosurgical. The highlight was that we often get this patient presenting to us with sensory ataxic neuropathy. So sensory ataxic presentation, whenever we get, we straight away go for NCS. And NCS, and the patient mostly is diabetic, we often come in dilemma that whether it is diabetic peripheral neuropathy or we are dealing with something else that can cause sensory ataxic neuropathy. But we want to highlight, if we see the NCS, we can see whether it is demyelination in most of the cases, but whether it is distal demyelination, mid-segment demyelination, or proximal segment demyelination. We found a case where distal latency was not much less, but conduction velocity is, it is very much low. So it is predominant mid-segment demyelination. So we proceed for paraproteinemic neuropathy. As we know, if we get cases of carpal tunnel syndrome or DADs, where there are distal segment demyelination predominant, but in most of the paraproteinemic neuropathy, it's mid-segment demyelination. But whereas in CISP or CIDP variant, it's predominant proximal segment demyelination. So we proceed for it, and paraproteinemic neuropathy, we have done all the things like SPP with immunofixation with kappa lambda light chain assay, where we got IgA kappa with high kappa lambda ratio. Bone marrow biopsy was done, bone marrow biopsy was repeated normal. So it was a case of paraproteinemic neuropathy, and patient is very much improved with steroid.
One teaching point is for us that any case of diabetes having neuropathy, all the time they are not diabetic neuropathy. And if you were left it as such, the patient would have worsened. And in diabetes, steroid is contraindicated. And this patient has paraproteinemia and he responded to steroid. So that's the simple thing that diabetes neuropathy doesn't mean all the time diabetic neuropathy.
If I may ask you a question about your previous case.
Sure.
I'm very ignorant about the second case I may not know. But in the, if I'm not wrong, in verticals, cyclogen we get generally still like is that correct?
Yeah, so
and it's, I think the median
In fact, for Wernicke's, that is not the classical picture. That's described picture, but not classical picture. You're right that bilateral symmetrical, mammary body, median thymic, that's the classical picture. The 6 patterns, what he told about that, one pattern fits with that. Regarding Wernicke's, it's seen in alcoholic, but not all the time. It can be nutritional also. And the patient was living alone, and we could find out that he was neglected nutritionally. So that can be one possibility.
And actually, the signal changes are in the parental rather than the third now is a complex.
Yeah.
It's more on the parental. Cerebral parental.
Yeah, cerebral parental, and I found that in the MLF region, and
More
yeah. Anyway, afterwards, he just brought the image, and we can see that what he was talking about, bilateral symmetrical.
Because it's generally bilateral, he's learning, as described earlier.
Dr. Sepgupta?
I swear to fulfill to the best of my ability and judgment this covenant. I will apply for the benefit of the sick all measures that are required, avoiding those twin traps of overtreatment and therapeutic realism. I will remember that there is art to medicine as well as science, and that warmth, sympathy, and understanding may outweigh the surgeon's knife or the chemist's drug. I will not be ashamed to say I know not, nor will I fail to call on my colleagues when the skills of another are needed for a patient's recovery. May I always act to preserve the finest principles of my provider and help to preserve it, which allows me to enjoy life and art.
Start our resume now, because what happened? All our everybody comes up at this time, and there is a few cases discussed, and this oath taken, and then they go away to their daily work. So we are left with the neurosurgeons now, so we can continue. Sorry about the little delay for that.
Thank you, sir. It's a good practice and must be followed every day.
And we do everything now.
I call upon Professor Wakato to speak on neurosurgery education in Asia.
So good morning, everyone. First of all, I'd like to thank you very much once again, Robin Sepgupta, and also the senior delegates and colleagues and friends. Thank you very much for a kind introduction of the chairperson. I want to share how we can improve both Asian countries' education. So Asia is quite huge, and some borders of the Eastern Asia or Middle East. So several points, because education is we need a manpower. Every institute needs a manpower, and also the coordination at the various levels, and the professional management, and the cost. the cost effectiveness and also infrastructure is another very important factor, and also the money, the funds. And so aspect of the education is we should obtain the knowledge and also the surgical skill and the research activity. And also we should learn the medical leadership. And also, just like Robin, humanity. We can always sit beside the patient. So the education in developing countries is many problems, I think. So because of the different timing of the training in each country, such as India or Sri Lanka or Laos or Hanoi, Vietnam, and also need for more achievements in neuro-oncology and spine surgery and skull-base surgery and vascular surgery. So some countries still they cannot get the vascular cases because some the problem of the radiological diagnosis and also the manpower or stroke center. And the problems are facing with the proportion of the population and neurosurgeons. There is not sufficiency. India is 13 billion now. Yes. Japan is 1/10. But now we have 10,000 neurosurgeons and 600 lady neurosurgeons here working. But we must do everything from the super acute until the nursing home. So a little bit different, including of the endovascular. Almost 100% endovascular procedure done by neurosurgeon in Japan. And the education of the patient is not good. And also the neurosurgical training effectiveness and no luxury operation, not enough for the good instruments and the ability of the medical care. So need for the advanced imaging and the meticulous surgical techniques included instruments. So I discussed with Dr. Robin this morning. So maybe some of the young doctors can visit such as the Christian or Shubin place, even 1 month. I think you can see the surgery, and also sometimes you can scrub. You can scrub the assisting of the surgery, and at night you can practice on the bypass something. I think so. In that purpose, I think 1 month or sometimes 2 months is enough. So Dr. Shubin, the place can provide the lodging and food. I think just we can discuss later. And helping the education improvement is convince a neurosurgeon who should practice in their country. So in their country is most important because once they fellowship in United States or Europe, never come back to their own countries. That is a big problem, especially Africa or developing countries. The organized neurosurgeon university teachers or neurosurgical society focus on advocating with the government and training within the countries. And another factor is operating rooms and equipment. And not only the neurosurgeon, but also we can educate the nurses and radiologists and the neurologists, neuroanesthesiologists. And also equipment such as microscope and the aneurysm kit and the microsurgery set. And also the ICU, the training is very important. ICU, the pre and post-operative care at the high standard care is very, very important for the severe patient. So the so-called excellent centers. So interact with the work community, the ACNS or WFNS, ASNS or ANS or CNS. So the such initiative is in each country is very important. So this is just a small AVM. Of course, all you know that there are 3 modalities of the treatment: surgery, embolization, and the radiosurgery. Dr. Shubin is, of course, his specialty is moya, so he can do the 9 cases per day. And also the AVM, he is a very large specialist. So today we can get the ICG. So this is just how this is just real-time information during the surgery. So time to time, so we can get such kind of fresh information during the surgery is very important. So this is just I want to show the ICG. This is a temporal lobe with a small AVM and with dilated the draining vein. So this is just temporal lobe. So you can see which one is a feeder, which one is drainer. It's very easy to understand. And how much ejection and how much flow of the nidus itself. I think those quite important information we can obtain with ICG. So at the beginning, just we can put a temporary clip of the main MCA, and then we can decide, and we can put all of the temporary clip on from the surface which we can obtain, and then next step is decide dissection plane and the meticulous, precise resection. And step by step, then just we can do the ICG. So this case is embolized 2 times before surgery. So this is just a surgical skill, and now it's already the slow the circulation of the venous drainage. But still, almost 90% has been dissected, but still some flow of the draining vein. That means it's still some feeders or still some remnant nidus we must check. So at the last moment, so we remove of the temporary clip. Never ever ask anesthesiologist to increase the blood pressure. We can keep the blood pressure around 80 during and the post-operative surgery. So this is the recent, just we can combine the many information during surgery. This is for 800, how the which vessel become from the pure draining vein to the normal draining vein. And also this is a 4800. This is just for the pentero microscope. So then we can realize. So this is not for the super doctor's case. This can be the usual case with this all technologies. So we can do the surgery very safe, and we do not see the unexpected the bleeding during the surgery. So otherwise, this is forever is just only for the super master case. So I think this is once again, this is not so big one. This is just grade 2, small one. So you can do. So this is before surgery. Just if possible, you can combine an embolization, especially the nidus from the bottom. So this is a recent deburr. We can put the color of the vessels. Then the monitoring and also for 800. So the surgery can be more easily to understand which we can touch or which we cannot sacrifice of the vein, because we do not know which one is the feeder, which one is drainer. With those information, just you can realize and not be so hard, just very meticulous dissection, and that the white vessel is the embolized one. Then deburr tell us deburr is just the usual surgical field plus ICG. So we do not need the reconstruct in the brain. So this is almost the last part. I think that this AVM surgery became very, very safe and very, very standard. And back to the education. So because just why I showed such a AVM case, because recently that we should the more obtaining of such information and also the high tech during the surgery process. And also the mentor is very important. So Dr. Kano is my mentor, one of my mentors, and Dr. Raja from Pakistan. He passed away unfortunately. So they and all those senior, the teacher of mine. So especially the India. Ramamurthy, the late Ramamurthy, he is a great neurosurgeon, and Mauritius, and Dr. Ota, he passed away recently. Dr. Kano is now 77, but still working, very hard work. Always on to me, how are you, something like that. And also Dr. Sami is maybe the mentor of most of us. And he is has a very nice humanity, because this is you can realize, because the 3 doctors has badge on the coat. So that is from North Korea, and the tall one is Kyu-san Lee is from South Korea. So during the Congress, that he unites the North and the South. So I think the master of the teacher is not only the knowledge and high skilled doctors, but also the very the humanity. And Dr. Kano, he is almost 24 hours dedication to the patient. He never go back home, maybe once a month. So, and always having such a conference, such as this is the Yasaji at that time we invited, and he demonstrated fiber dissection at the laboratory place. And for the young doctors, I think they can sit side by side, and they were taught by masters. There is a good chance for them. And so this is the recent, I went to Hanoi with about 10 doctors. So Hanoi is, and also that dog hospital is biggest hospital in Vietnam, and high volume center. And so we did the live surgery, and also at that time there was AVM case. So on the same day they embolized. Then 2 hours after I did the surgery and injection. So this time we invite Franco Salvadai from the World Federation, and also Vietnam has a lot of trauma. So we had the trauma symposium. So the short mention about the Asian Congress, because it is established in 1993, and at that time, 100 young doctors were invited to our place. Maybe you can find some Indian guy, Dr. Mishra, or the son of the, I don't know where he is now. He's working. Dr. Ramamurthy's son, yes. And Dr. Ramesh, no, several doctors from India at the time. And also the 6th Asian Congress was held in India. The president was Mishra at the time. So that was 2006. And so this is 10th Kazakhstan. This is the Central Asia. So before I went, So it's just like steps for horses and cows, and but now it's after the oil and still it became legal. Yeah. And this is Indonesia 11th. 2016, every 2 years we had a congress, ACN's congress. So just maybe the Dr. Kano, or he was the president then. So Dr. Kano, and then Ohata from Japan, and young doctors, the executive committee meetings. And this year we will have already 12, so divide. It's focused on the Middle East, because Middle East is very sad. So many sad countries because they are still doing a war. So we decided why, because we want to invite the young doctors from such countries. And also another my mentor is Dr. Sano. Of course, you know, he is still doing surgery 3 times per week. So we did bypass hands-on, and also Dr. Yashanji, and Dr. Atos, he passed away because of sudden heart disease. And also we should focus on the female neurosurgeon. Of course, Kanaka is always our mentor, who is sitting in the center. And so many lady doctors are working in the world. So we should encourage them. And also in 2016, December, so in India, because they established the first women neurosurgery foundation. So now you have about 50, I think, lady neurosurgeons in India. They are very happy working, I think. So you were in the field, I think. And Dr. Sepgupta is very supportive, and so many doctors are joining. Maybe some of you they know the female doctors, I think. In Japan, there is some of the university already over 50% is a female student. So how we can encourage them to become a neurosurgeon or surgical site. Otherwise, the surgical site must close the doors. So the divide, Morocco, Kazakhstan, Indonesia, Pakistan, and Nepal. Many lady neurosurgeon and also the students want to seek to become just like the role models. And also the fellowship. Just you can contact maybe the America or Europe, I think, just stand at the corner. So I think that's the patient maybe. Sometimes they cannot join the conference. So maybe you can find the suitable place. I think 1 or 2 months is sometimes enough. Thank you very much.
Cool. Thank you, Dr.
Professor Sepgupta, particularly for 2 counts. Number 1, I find I'm the only speaker with an Indian passport in this entire meeting, and I think therefore I should thank him on behalf of all the Indian neurosurgeons. I am, however, not speaking on behalf only of neurosurgeons in India, but on behalf also of the International Society of Pediatric Neurosurgery, when I speak to you about training in pediatric neurosurgery. And this is basically what I'm going to talk to you about in the next 20 minutes. Why is training in pediatric neurosurgery necessary at all? And I'll spend a little bit of time on this because this is a question that everybody asks everywhere in this country and indeed in the world. And then, of course, look at what training facilities in pediatric neurosurgery are available to us at home and abroad, and what are we doing with training pediatric neurosurgeons in this country. Before I go any further, it's probably worthwhile to tell you that in the year 2024, 67% of the population of this planet will be below the age of 18 years. Just a piece of statistics we often forget when we wonder whether we should become adult or pediatric neurosurgeons. This is the first ever article that came out talking about subspecialization in pediatric neurosurgery. It was written by my first boss in pediatric neurosurgery just when I was about to leave the Hospital for Sick Children, Toronto, and it was written by Professor Harold Hawthorne. And he wrote, and this is very significant because this is what he wrote. He wrote that the child has a very different physiology from the adult and is prone to specific, unique disease processes, and therefore advocated for pediatric neurosurgery to be a separate specialty. Many years later, this article came out in the Journal of Neurosurgery Pediatrics, which highlighted the fact that in fact pediatric neurosurgery was probably the most unpopular subspecialty of neurosurgery in North America. And I hate to tell you that it's probably true in this country as well at the present time. Why do we need training, first of all, in pediatric neurosurgery? We're all trained in adult neurosurgery. Why the hell does that not suffice for us to operate on children? And a lot of us in this room actually do operate on children. And I think one of the main reasons is this, that some diseases of children do not occur in adults. So as an adult neurosurgeon, you will not be subject. You know, a child is not a small adult, and these two creatures may be the same species, but they are completely different in appearance and behavior, so one may lead to become the other. And I just show you, as an example of some diseases not occurring in children, the photograph of a young guy who visited me just a few months ago. This is what he looked like. He had this constricting band. He had his precordial pulsation visible through his sternum. And if you turned him around, he had a band right round, and he had a swelling there in his neck, and a general neurosurgeon somewhere in this world had operated on that swelling. Unfortunately, 6 months after this operation, and the operating note said that he had repaired a meningocele in the cervical spine. A few months after that, he developed spastic paraparesis and came to us with this lesion. Of course, and that's what he looked like from the side. I don't know how many of you would have seen things like this, but this is a constrictive band, like an amniotic band. And that's the MRI that he came to us with. And of course, most pediatric neurosurgeons in the world that you show that to will look at it and say, oh, that's obvious what that is. And that's a condition called a limited dorsal myeloschisis, which has only been described by one of my senior friends and colleagues, Professor Dackling Tang, about 8 years ago. And that's what it is. So what happens here is that the spinal cord comes like that, gets tethered to the skin and comes back. So if you repair that meningomyelocele there, it doesn't stop the tethering of the cord. This is just to show you that unless you know about this condition, it is impossible for you to treat it. And that's the post-operative MRI after you've done a proper untethering to this LDN. So in fact, we published this some years ago because I got a whole collection of LDMs that were missed and operated as other lesions, and this was published by us in Child's Nervous System some years ago. So there are some diseases that are not only unique to children, but that require multidisciplinary approach. And this can be psychological, physiological, from the point of view of pediatrics. And here's a young girl who was brought to me by her parents, and she traveled around 7 cities in this country before she decided to come to us, presumably because they ran out of money at that point of time. And of course, if you look at her, she's got a fixed torticollis. She's got no neurological deficit. And the parents say she's going to school, everybody's laughing at her, can you get her neck straight? And that's what she looks like with that fixed torticollis. Now, when you look at her CT reconstruction, that would not win a prize in any beauty contest. And if you really study that well, as you can see there, that's the entire cervical spine. Those are the ribs. So that's where the cervical spine ends and the dorsal spine begins. And I have to say, I work in a hospital which has a very strong orthopedic spine unit, but we generally don't let our orthopedic spine surgeons touch spines of children like this. And therefore it's done by pediatric neurosurgeons. And if you look at the scans further and you look at the MRIs, this child has a number of congenital problems. There's a failure. There is a condition that we have described about 8 years ago as a lateral pro-atlas failure syndrome, jointly with Professor Mutsugumai from Madurai. And this is a non-resegmentation of the proximal sclerotome, so there is no pro-atlas on one side. These children tilt, they have no lateral mass of the occiput or C1 on one side. And of course, fortune favors the brave, and I don't know how I managed to get away with fixing this child and getting an X-ray, and I'm happy to tell you she's in class 6 now and walks pretty straight still. But for operating on a child like this, you really can't do that as a pediatric neurosurgeon on your own in this planet. You have to understand that there is a basic science of pediatrics, and there is a lot of epigenetics that intermingle with the basic neurosciences that we deal with today. And this multidisciplinary care is necessary. Look at this tumor, which you rarely see in an adult. This is a small child who's 2 years old, presents with a tumor like this. And of course, you have to do it with a pre-sigmoid ventrolateral, if you like, approach. And that's what we did. It's a small child, and you can see these are the pre-op scans on the top, and these are the post-op images below. But for a child like this, post-operatively, you need to keep the child in a pediatric intensive care, which has to be a dedicated pediatric intensive care. I mean, in fact, in my own practice, I operate in a separate theater, which is our pediatric theater, when I do pediatric cases. The anesthetists are completely different. Even the operating technicians are different. And post-operative patients that I do any such surgery goes to the pediatric intensive care. And every single child that is admitted in our hospital is admitted jointly under the care of myself and a pediatrician or a neonatologist, depending on the age of the child. Because I think as neurosurgeons, we are not really equipped to look after the physiological requirements of 1-year-olds or even 1-day-old. And as I speak to you, one of my patients who is 15 hours old is being operated by one of my colleagues. And for babies like this, you really need to have a dedicated intensive care unit, and you need a neonatologist to be able to look after these children. Otherwise, it's not adequate. The other thing, of course, is the idea about monitoring. And I'll just show you this young girl. This is a patient of Professor Bhattacharya, the chairperson for this morning. And this girl came with an X-ray like that, and sent to us by a pediatric orthopedic surgeon who said she's got no vertebra. Of course, she didn't have a vertebra. What she had, in fact, was she had cartilaginous vertebra that had not ossified. And this is what it looked like. And of course, these are children that you have to do neuromonitoring on very, very carefully, and it's not so easy to do. That was her MRI, and you wonder, looking at a spinal cord, how she was working at all in the first place. This is what we did. We reconstructed her front and back. And if you look at that pre-op scan and compare that with the post-op scan, you can see you can get these children to get pretty straight, pretty good. But you have to do very intensive monitoring, and you need to have a pediatrician. You also have to understand the cause, and this is the cause. And unless you're involved with the pediatricians, you're not going to be able to make the diagnosis. And this is, in fact, a type 1B disorder of congenital disorder of glycosylation that caused this. And this is just another one of our children, just to show you that the approach to the children's spine is a little bit different from adults. And again, you can see the amount of that kyphosis. Adults are fine if you put them on traction. Children are not fine if you put them on traction in the ward. We put them on traction, allow them to move around in wheelchairs. We even allow them to walk around on traction because they hate it otherwise. And of course, this is just another reconstruction. The third reason why we have to do specialization in pediatric neurosurgery, because our understanding of pediatric diseases is changing and ever evolving. And of course, I always say when I talk on in a CME program, that it's a bit like the Red Queen's race in Alice in Wonderland. Anybody knows the Red Queen's race in Alice in Wonderland? My favorite book. Well, in Alice in Wonderland, when Alice starts running with the Red Queen, she finds that the faster she runs, she's still at the same level as the Red Queen. So she turns around and tells the Red Queen, I'm not running anymore, because even if I run fast, I can't keep up with you. And this is what the Red Queen answers. This is a quotation from the original Alice in Wonderland, Lewis Carroll, and I say this to all our residents. And this is what the Red Queen says. She says, my dear, here we must run as fast as we can just to stay in place. And if you wish to go anywhere, you have to run twice as fast. And that's why you need to know a little bit about the disease evolving in pediatric neurosurgery, because you have to run twice as fast if you want to move forwards. Simply running keeps you in the same place. This is a disease that all adult neurosurgeons in this planet treat. This is a child with hydrocephalus. But our understanding of this disease has completely changed and evolved over the years, and this is some of the newer concepts that we've developed of cerebrospinal fluid dynamics. We now know that there is in fact an evolution theory in this dynamics and how it's changed. We understand from a lot of work done, again, by a very close friend who's visited this city about 5 times, from Japan, Professor Shizuo Oi, who's taught us that you have these minor CSF pathways in children, which is completely different from adults, and that these minor CSF pathways help train children hydrocephalus. The technique of operating on hydrocephalus has changed. Of course, endoscopic third ventriculostomy started. We now know that it's been replaced. I call the hydrocephalus period the pre and the post choroid plexus cauterization period, and of course endoscopic choroid plexus cauterization is now emerging more and more as a very useful way of treating some of these children, and that's the results of the most recent study published in North America. In fact, there is a prospective study, and we have just enrolled onto this prospective study of doing endoscopic third ventriculostomy with choroid plexus coagulation. It's all the business of stopping that excess water in the brain, but the techniques of doing it are evolving with time. And of course, I'm not going to go through the details of that. We ourselves started our little bit of our very simple, modest work on hydrocephalus, because when I came back to this country in 1995, I discovered to my horror that the amount of shunt infections that we had in my first 5 years of practice was significantly higher than what I'd encountered on both sides of the Atlantic that I had done my training in. And that led us to wonder why these infants were developing hydrocephalus, having shunts, were getting infected. And this is a study we published in Pediatric Neurosurgery way back in 2006, where we checked the CSF of all kids that had shunts, that had hydrocephalus, and we discovered that as many as 35 to 40% of kids that masquerade, of infants in this city that came to us as aqueductal stenosis producing hydrocephalus, actually had post-infective hydrocephalus. And as you well know, Ben Warf has replicated and produced exactly the same paper from Uganda 4 years later. We also decided when we got the endoscope that we were going to do endoscopic third ventriculostomy on everybody, and as you know, fools rush in where angels fear to tread, and I think we rushed in and did endoscopy everywhere, and of course published our failures in post-infective hydrocephalus in the Pediatric Journal. It caused us many years later to really try and understand what happens in post-infective hydrocephalus when we wrote this review article in Child's Nervous System. And of course, by then, we had developed quite a lot of experience. Just to show you, even in TB, you can do endoscopic third ventriculostomy, and this is a post-tuberculous endoscopic third ventricular. You can see the tubercles in the floor of the third ventricle itself, and that's quite a unique thing that you don't always see. Of course, we also learned that you cannot do a simple endoscopic third ventriculostomy in post-tuberculous hydrocephalus, and quite oftentimes there is that extra layer of arachnoid, and you have 2, 3, 4 layers of arachnoid that you have to go through with the endoscope before you can do this satisfactorily. But for these children with post-infective hydrocephalus, this is not an area that you go occasionally to. You must have driven down this road plenty of times before you can do these sort of procedures. You see, this is so thick floor from post-tuberculous that I need a stronger other instrument to perforate the floor. I wouldn't have dared to do that in my first few years of doing endoscopic third ventriculostomy. So this is just to carry on and tell you that we have actually done a lot of studies on these children, whether to shunt or not, what to do with these hydrocephalus, and I'm not going to bore you with all this. I'm just showing you this picture. And this is something, again, why pediatric neurosurgical training is essential. These represent ultrasound scans prenatally that I have seen in the year 2018. So these are prenatal ultrasounds that have been sent to me by obstetricians this year, and all of them have intracranial cysts. And the reason why I show it is this has become increasingly common with obstetricians finding prenatal ultrasounds. They have this so-called congenital screen, and they're sent to you, and then you get all these little cysts, and you have to comment on what happens. And of course, the majority of them are choroid plexus cysts. They are found at 20 weeks ultrasound, 22 weeks ultrasound. The good thing about them, and a lot of neurosurgeons, adult neurosurgeons, will see them, tell them that this child should have a cesarean section, should have an ultrasound at birth, an MRI at birth. The truth of the matter is, majority of choroid plexus cysts disappear at 28 to 30 weeks. All you tell the mother is, go and get an ultrasound at 30 weeks and come back. It won't be there. And when it's not there, they think you're God's gift to neurosurgery. Of course, we know that they've involute spontaneously, majority of them at 28 to 30 weeks. And that's the whole list of, because I just wanted to show you. What about training facilities in pediatric neurosurgery as they exist at the moment? This is the website of the International Society of Pediatric Neurosurgery, whose hat I'm going to put on at the moment as chairman of the education committee of this international organization. And we have a website. The International Society has actually been the only international society of neurosurgery that has been proactive enough to have a website which has a textbook on it. So if you're a member of the International Society of Pediatric Neurosurgery, you can actually access this entire international ISPN guide to neurosurgery with chapter by chapter, which different subsection editors have edited, and we put it all together in a textbook. So you can get a free online textbook with all the modern details of pediatric neurosurgery. This is an evolving textbook. So for example, if I write an article on limited dorsal myeloschisis, I can actually go into this textbook, tell the editor I've got some new things to write, and send it to the editor, and it's updated. And every time we give a lecture anywhere in the world on behalf of the International Society of Pediatric Neurosurgery, this lecture must mandatorily have the summary of that chapter. And if as a professor giving a talk on that I disagree, then I can write to the editor and exchange. So this is an evolving textbook which is available, and I think this is one of the very good things that you can access if you want information on pediatric nursing. We have a lot of courses all over the world that is held by the Education Committee of Pediatric Neurosurgery, and a lot of the purpose of these courses is to teach general neurosurgeons the nuances of specialized pediatric surgery. If you go to the ISPN Neurosurgery website and go to International Fellowship, and we've just heard a professor tell us about fellowships of the Asian Society of Neurosurgery. If you go to the International Society of Pediatric Neurosurgery and look at their fellowships, these are the countries that have their fellowships. There are 3 fellowships in Japan, and you'll be very happy to know we have 1 fellowship in India, and it happens to be the institute in which I work. And this is a fellowship which is recognized by the International Society of Pediatric Neurosurgery, so you get a certification not from me, but from the International Society of Pediatric Neurosurgery. Another important reason why pediatric neurosurgeons need to be specialized is what I call this wonderful thing, the Hawthorne Effect. Anybody knows what's the Hawthorne Effect? We have a lot of young, talented, bright people like Haritos sitting around, and I'm sure they know everything about this. The Hawthorne Electrical Company was an electric company in the UK that started this principle. And it's basically what's called an observer effect. So it's a type of reactivity in which the individuals modify to improve an aspect of their behavior as long as they know they're being watched. So if I'm doing surgery and I know that Shuchandra is standing behind me trying to see how I repair this split cord malformation, then I'm more concerned that I have to do it perfectly. So that's what's the Hawthorne Effect. It's been well established. There's a whole textbook on the Hawthorne Effect in neurosurgery, telling you that quality assurance comes from being informed that your data is going to be looked at and analyzed by somebody else. And I think that's quite important in pediatric neurosurgery. We have some terrific data. I also put this in because of Mr. Sepgupta, because this is a recent publication which shows that the mortality and morbidity of subarachnoid hemorrhage is inversely related to the volume of patients you deal with in your center. And therefore, this is equally true in pediatric neurosurgery, and therefore we really need centralized super specialty centers where there is training in pediatric neurosurgery to do complex pediatric neurosurgery cases. Just to finish up with what we're doing on behalf of the Indian Society of Pediatric Neurosurgery, whose hat both Shuchandra and I in this room are wearing at the moment. Shuchandra has just been inducted into the executive committee, and I am unfortunately the president-elect. So the Indian Society of Pediatric Neurosurgery also has an education program, runs a CME program jointly with the International Society, and from this year we'll run a mid-term CME program. It also has a fellowship. This is a fellowship also in our institute, and this rotates with an institute in the United Kingdom. 1 year in Kolkata and 1 year in Old Age Children's Hospital in the UK, which is in fact the largest children's hospital in Europe. We have actually got the General Medical Council to exempt all our students from the PLAB exam. So they do not give exams and they go and work there as Year 5 registrars. The Indian Society of Pediatric Neurosurgery has now started for the last 10 years been publishing this Journal of Pediatric Neurosciences. Again, for my sins, I happen to be the editor of this journal at the moment, and I would encourage all of you who have interest in pediatric articles to send it to this journal. If you really look at full-time pediatric neurosurgeons that do no adult neurosurgery in India, there are 6 of them, believe it or not. If you look at the population in India today, and if you look at the data that is available, we need 800. So there's 794 vacancies in pediatric neurosurgery for young neurosurgeons in this room. There's no money though. I just thought I shall tell you that my basis for giving this talk, and the reason perhaps why Professor Sepgupta wanted me to do this talk, is because I happen to chair a number of education committees of pediatric neurosurgical societies, including the Asia-Australasian Society of Pediatric Neurosurgery, and have just now, for the first time in this country, a university, the West Bengal Health University, has bestowed upon us the duty to run a post-MCH diploma course in pediatric neurosurgery, and the West Bengal Health University has just approved of such a course, and it's the first university in this country to have approved of a specialized course in pediatric neurosurgery post-MCH. Thank you very much. Anybody has any questions, I'll be happy to answer.
Why do more pediatric neurosurgeons not do exclusive pediatric neurosurgery in this country?
Because it's the same reason why talented neurosurgeons like Paritosh Pandey do not have any interest in pediatric neurosurgery, because you join corporate hospitals where there is no pediatric neurosurgery because there's no money in it.
But even in institutions, like, there are plenty of institutions in this country, and there are plenty of pediatric neurosurgeons when they go to the.
See, I think
most of them.
On a serious note, Paritosh, it's all a lot got to do with mentorship. So, you know, when Professor Mahapatra was at the All India Institute of Medical Science, there's a lot of people that were interested in doing pediatric neurosurgery. I'm talking about institutes. But when he's not there, and there are 2 units headed by 2 very learned professors, neither of whom have any interest in pediatrics whatsoever, the number of pediatric neurosurgery cases have significantly declined. If I'm not wrong, a lot more pediatric neurosurgery was done in your mother institute when Professor Shastri was the head than is done currently.
Do you think that morbidity and mortality in pediatric group of patients are a little bit more than the adult? That could be the reason that the people are not much interested.
Yes, definitely. There are more than adults across the board, not for neurosurgery, for all conditions. I'll tell you another reason. I did want to say this because this may not have impact on a lot of international visitors we have. But I don't know whether you know, but no insurance company in this country covers any congenital disorders. So there is no reimbursement for anybody with a congenital problem. And if I now operate on an adult with a Chiari malformation, I never write a Chiari malformation in the diagnosis. I write cerebellar herniation or something like that, because the moment you